Good afternoon. My name is Jennifer Sorrell, and I'm the Executive Director of the UCI Anti-Cancer Challenge. Thank you all so much for joining us for today's webinar. If you'd like to ask a question during today's session, please use the Q&A feature at the bottom of the screen. Next slide. Now I'd like to introduce our moderator and first speaker for today. Dr. Patel earned his medical degree at the University of Oklahoma Health Sciences Center. He went on to complete an internship in general surgery and residency in urology at Boston University Medical Center. He joined the Department of Urology at UCI in 2016 as a fellow in endourology under the mentorship of Dr. Ralph Klayman and Dr. Jamie Landman. His clinical practice emphasizes all aspects of minimally invasive urology, including robotic, laparoscopic, percutaneous, and needle ablative surgeries. He currently serves as the Vice Chair of Education and Research in the Department of Urology, as well as the Chief of the Division of Endourology and Director of the Kidney Stone Center. An innovative urologist and surgeon, Dr. Patel's research interests include outcomes-based studies on minimally invasive surgery for kidney cancer. Additionally, he has a strong focus in evaluating the methodology used in percutaneous surgery for large kidney stones with the goal of improving patient outcomes. Lastly, he actively leads projects in the endourology lab in evaluating new technology that may change the way surgery is practiced today. I'll now turn it over to the esteemed Dr. Patel.
Jennifer, thank you so much for that kind introduction. And I'm so excited to present today regarding advances in minimally invasive genitourinary treatments. So next slide. Oh, I got it. I'm sorry. Excellent. So first and foremost, I want to let you know that outside of heart disease, cancer is one of the leading causes of death in the United States. So all of the work that we do here at UCI, and especially the Anti-Cancer Initiative, is to really make a huge and impactful difference in folks that are affected by cancer, not only in it being the leading cause of death, but also all of the challenges that cancer diagnoses and the treatment and things that come with it. So again, it's the second leading cause of death in the United States, just behind heart disease. So the first and foremost, I'm going to break this up into three different topics: prostate cancer, bladder cancer, and then kidney cancer. And as I'll explain later, I'll let you know the importance of each. So in looking at the most recent data in 2023, the second most diagnosed new cancer in the United States is prostate cancer. Breast cancer makes up the majority of the, also along with breast cancer, prostate cancer has the second most diagnosed cases in the United States. So it's an important topic to look at. From 2013 and 2017, one of three cancers diagnosed in men was a urologic cancer. Of the over 300,000 urologic cancers diagnosed, a vast majority of them is in the prostate, followed by the bladder, the kidney, and then lastly, testis cancer. So what I'm going to show you is a couple of different things here, and some of the innovative things that we're doing here at UCI. And so generally, when a gentleman is diagnosed with an elevated PSA, what we've had to do is, in the past, if you can see on the screen here, this is a picture of a prostate. Right through the middle of that purple tube is a urethra, which is where you urinate from. And on the sides, what we did in the past was just blindly biopsy the prostate. You can't see prostate or potential areas of prostate cancer on an ultrasound, which is our primary way of doing this. So what we've done is we have a new fusion technology where we have patients go to get an MRI, and you can identify specific areas where prostate cancer might be. And as you can see here, the green area would be the areas of prostate cancer. And that's where we're specifically focusing on making sure we get prostate tissue from. What this has done is increase the detection of high-risk prostate cancer. In addition, one of the other things that it's helped out with is that some gentlemen have increases in their prostate-specific antigen, which is a marker for prostate cancer. And what we've been able to do with this technology is also rule out folks that potentially don't need a biopsy. But if they do, now we're doing smarter biopsies. So we're actually targeting areas rather than, as I tell my patients, we're not kind of doing this type of thing with a needle. We're actually focusing our efforts and trying to really diagnose where the cancer might be. Um, After detecting prostate cancer, then what are the next steps? What are the things that are going on now? And one of the more fascinating things that we're doing here at UCI is it's single port surgery, meaning typically in the past, prostate cancer was taken out by a large incision in the abdominal area. Since then, since the mid 2000s, and actually the first prostate ever removed by robotic surgery was done here with Dr. Allering at UCI. What we've now also transitioned to with Dr. Lee being here at UCI is that we're able to do the entire operation through one single port. And I'll show you what this looks like. So what you see here is that that cannula in the middle, using the Da Vinci technology, we're able to do a complex major pelvic operation to remove prostate cancer through a single incision that can typically be hidden right by the belly button. And you wouldn't even know that you had prostate cancer surgery. This is what the device looks like. It takes a team effort to do this and very skilled people to be able to do this operation. But as you can see here, through one port, you're able to go in and put in multiple instruments. And in doing so, really separate the area of the prostate from the urethra and the bladder, which is where the prostate sits. It gives us enhanced visualization. And in doing so, we've had great functional outcomes, and we've really pushed the envelope in how we treat prostate cancer. And that's a machine and spine intuitive. The other thing, and Dr. Ed Uccio here is doing it, is that oftentimes you have prostate cancer that's diagnosed, but your entire gland or your entire prostate's not affected by the disease. And one of the new things that we're doing is focal therapy, where we use high frequency ultrasound therapy to treat the prostate cancer. So as you can see here, the bladder's on top, the prostate's below. And what we do is we identify the areas of prostate cancer using MRI. And then using that information, using a specific machine where we can focus intense ultrasound treatment effects, such that we treat the area of prostate cancer while leaving the other aspects of the prostate behind. What that's allowed us to do is avoid the morbidity or the challenges that you get with any type of prostate surgery, specifically meaning incontinence or leakage of urine, and also erectile dysfunction. And here we're trying to do therapy not only more focused onto where your area of the prostate's affected, but just treat the cancer itself. So now moving on to bladder cancer, which if you know of anyone that's ever been diagnosed with bladder cancer, it's a very challenging disease to manage because it fits in this container which holds our urine, but in doing so, it often recurs, and it's a lot of treatments that end up having to happen for this. As you can see here, the top 75% of all new cancers behind breast in women, prostate in men, and just right there in the top 5 of that list is bladder cancer. And so it's an important thing that we're looking at here at UCI. And so as you see here, one of the things that we do here, it's early detection, easier removal, and smarter ways of following it such that we can identify recurrences. One of the things that we're doing, it's called blue light cystoscopy. On the pictures of the right, when we put a camera inside of your bladder to identify bladder cancer, what you see here is that the areas of the inside of the bladder all look the same. And so this is an enhanced and revolutionary diagnostic technique where you can see that bladder cancer that might be hidden will light up with this blue cystoscopy that we do. And so areas that we would have missed in the past is easily more detected and such that we can get treatment started earlier. And what this looks like here on this screen, again, it's blue light cystoscopy. It takes about an hour in the office, and you end up getting medicine that then is secreted into the bladder. And then you can identify, and these hotspots of bladder cancer will pop up using flexible instruments that cause a lot less discomfort than in years past. And with this technology, we're able to, again, diagnose bladder cancer earlier and also find those areas of lesion that we may have missed in the past. without this type of technology. So the third component of this is kidney cancer. So kidney cancer, and this is a screenshot of the trends in new cancer cases. And as you can see here on the left of the screen in men, kidney and renal pelvis cancer is trending upwards. So we're finding more of this. And on the right of the screen is in females, and that's the fourth most highest trend in disease found in women. So certainly this type of cancer is being detected more frequently and more recently. So again, here we try to do patient-centric treatment of kidney cancer. And what does that mean? One of the things that we've developed actually in our lab is using virtual technology, virtual reality, to show patients their own images and also the surgeon. So you can see here on the right side, at the bottom right, is Dr. Jamie Landman, our chairman. And what you're seeing is that a patient's actual imaging that's being able to be viewed with a VR headset where you can interact with a patient's anatomy, where you can see the liver here at the top of the screen. You can zoom in and see the blood vessels to the kidney. In addition, you can specifically locate where the tumor might be, and it allows patients to understand their disease process better, but also allows surgeons to figure out exactly where the tumor is, how deep the tumor goes in. And as you can see here, that bump on the kidney bean on the left side is a tumor. And what you see here is Dr. Landman is manipulating the organs. He can see and remove the kidney outside and see the depth of penetration of the tumor. And as he looks around here, he sees how closely it gets to the areas where the urine drains. He can put the kidney back. He can see what other structures and other blood vessels are going into the kidney. And we're doing this not only for kidney cancer, but also for kidney stones and also for patients that end up donating their kidneys, just to make surgery safer and improve the understanding not only for the patient, but also the surgeon himself. This is kind of neat. He's putting his head inside of the kidney as he looks and checks out the depth of how deep the tumor. And this is very patient-centric, where patients' own CT scans are then uploaded and turned into these virtual reality models that both the patient and the surgeon can manipulate. If you're diagnosed with an incidental tumor, which often happens if you get a CAT scan, because kidney cancer typically doesn't cause any pain, what we're doing here at UCI is taking the anxiety out of these small tumors that are often detected and doing a very simple procedure in the office, where on the right side of the screen, you can see a well-circumscribed tumor. You have a patient that's completely awake, and you can do a biopsy in the office, which takes about 15 to 20 minutes with little to virtually no pain and very minimal complications associated with this. The patient's completely awake here, and at the end of the procedure, a small band-aid's put over the area of the biopsy was done. And with this information, it allows us to perform less surgery and to do surgery only for those tumors that may cause a patient problems. Other things that we're doing here at UCI is a modality of treatment that's minimally invasive. It's called cryoablation. And so typically ways to treat kidney cancer are multifocal. One, it's surveillance, where you just watch a small tumor over time. Number two, you can do take out that part of the kidney, take out the bad part of the kidney where the tumor is located, and leave the rest of the kidney behind. That's still surgery. We do it robotically in laparoscopy with very small cuts, but still it's an invasive procedure that the patients have to go through. They're often in the hospital for a day or two. What we're doing now is we're using needle and needle ablative technology with our colleagues in interventional radiology to freeze tumors, and in doing so, treat the cancer. And at the end of the day, you have one small cut and needle that's placed into the tumor. You freeze it, and patients go home the same day. And so this is what this looks like. Here you identify the tumor. You can put the needle within that tumor. And what happens is an ice ball is created. And through that ice ball, the kidney tumor itself is ablated, meaning it's totally obliterated of the cancer cells. And it's a modality that's very useful for small kidney tumors less than 3.5 centimeters, which is one of the most common size tumors that are found today. Patients go home the same day. And so now what we've done, rather than cutting out tumors that may not be cancer, we've now brought the ability to see whether or not patients have cancer by doing a biopsy in the office. And then afterwards, if their tumor, based off of our virtual reality imaging, is in a location that's favorable for these needle ablative therapies, we're able to put the needle inside the kidney, make that part go away, and you leave the rest of the kidney behind, which is healthy, and you treat the diseased part of the kidney, which is where the cancer is. Again, I bring this up to you all in summary. One of the three most common types of new cancers diagnosed in the United States as of 2023, prostate, bladder, kidney cancer. And as I mentioned to you before, a few of these are on the rise in terms of new detection. So in summary, there have been numerous advances in minimally invasive options for both prostate, bladder, and kidney cancer. A lot of things that we were doing in the past, big open cuts, patients in the hospital for 7, 8, 10 days, we're able to do now with small cuts using laparoscopy, robotics, and even robotics has moved forward now that where we were doing multiple incisions to remove some of these cancers. Now what we're doing is able to do a lot of these operations with a small cut. And at UCI, we're fortunate to have a lot of different providers that can do a lot of these different types of therapy. And really, the idea behind this is to get people home and get them home and get back to their quality life and do these things that we weren't able to do in the past. And it's through the revolutionary things that we're doing, not only with imaging, with biopsy, and with treatment, and finding cancer such as bladder cancer in terms of earlier detection, and also finding better and safer ways of treating this. As I mentioned, it's a team approach, and this is our team led by Dr. Landman in the middle. We recruited Dr. David Lee, who's one of the foremost prostate cancer surgeons in the world, to do single port prostate removals, and certainly multiple members of the team that we work together with to treat these very significant and life-altering types of diseases as minimally invasively as possible. The other side of that is that not only does our team work with each other, but we also work with our close colleagues in hematology, oncology, and Dr. Marr has been a wonderful partner. I'll introduce you here in a second. So thank you so much for your time. I really appreciate it, and looking forward to answering any questions after Dr. Marr's lecture. Thank you. Perfect. Hey, Dr. Marr's there. Perfect. So it's my pleasure to introduce Dr. Nataliya Marr. She and I have had a number of patients that have seen us both, and she's a good friend and colleague. So Dr. Nataliya Marr is a board-certified medical oncologist who specializes in genitourinary malignancies, including prostate, bladder, renal, and testicular cancer. Dr. Marr received her medical degree from SUNY Downstate Medical Center in New York City, where she completed a residency in internal medicine at Lenox Hill Hospital. Next, she completed a fellowship in hematology oncology at the University of Connecticut Health Center in Farmington, Connecticut. In addition to delivering patient care, Dr. Marr is involved in the design and supervising of clinical trials at the UCI Health Child Family Comprehensive Cancer Center. She has authored multiple peer-reviewed publications, and her work has been presented at numerous national conferences. And not only that, she's a wonderful colleague and friend and has helped me out a lot in taking care of our complex patients together. So Dr. Marr, thank you so much, and the floor is all yours.
Thank you for that wonderful introduction and great lecture. So I am a medical oncologist. So unlike Dr. Patel, I have nothing to do with surgery, but I work with him a lot. As he said, this is a team approach to genitourinary cancers. And I wanted to shift gears a little bit and talk about prostate cancer, which is one of the most common cancers in the United States. And talk about it in a sense of what new and exciting treatments do we have available nowadays compared to kind of standard old school chemotherapies. Where is the prostate cancer field heading in the future? And what advances did we have in the last few decades? Next slide, please. So these are my disclosures. Next slide. So just to set the stage a little bit, so prostate cancer is, like I mentioned, is one of the most common cancers in the United States, and the median age at diagnosis is about 66 years old. You can see on this bar graph that the bar with the highest incidence is between 65 and 74 years old. However, as we look on the right, the median age at diagnosis, the median age at death is actually much later, about 80. And the highest bar graph here is between age 75 to 84, and then closely following it is age of 84 and older. So there is this latency period between median age at diagnosis and median age at death with prostate cancer, which really reflects its diversity and diverse biology of the cancer, because you have some prostate cancers that are fairly slow growing and some that are fairly fast growing. Next slide. In terms of how most patients get diagnosed, the vast majority, 79%, get diagnosed with localized disease confined to the prostate. Some patients, about 12%, get diagnosed with lymph node positive disease. And these are lymph nodes surrounding the prostate area. And then only about 5% get diagnosed with cancer that has spread beyond the prostate and the lymph nodes. Next slide. If you lump all of these patients together, the 5-year overall survival is pretty good, about 98.6%. But if you separate these patients out by stage, you can see that patients with localized prostate cancer and prostate cancer that has spread to regional lymph nodes do very well at 5 years. 100% are alive at 5 years. However, if we go to patients with metastatic disease, the ones where the cancer has spread beyond the regional lymph nodes, you see a drastic decrease in 5-year survival to roughly about 30%. So that's the patients that we really need to focus on. How can we improve therapies to make these patients live longer? Next slide. So this is a very busy slide, but it represents prostate cancer broken down into, I guess, boxes or stages of the prostate cancer continuum and what treatments we have available. And on the left, you have patients with localized prostate cancer that typically get treated based on their risk of cancer spreading. And choices here would be things like surgery to remove the prostate, radiation therapy. Sometimes if the cancer is small and not very aggressive, we can use localized techniques or even sometimes just surveillance. Sometimes we use drugs like hormone treatments or chemotherapy in this setting for patients with very aggressive or more advanced cancers. Then once these patients get treated, sometimes the treatment does not cure them and their PSA starts to rise over time. And if you, let's say, were to do some kind of imaging or a scan, we don't see any evidence of metastasis or areas of spread. So in a situation like this, it's called biochemical recurrence. And we have options there as well. Partly they depend on what the patient was treated with in the localized setting. But sometimes we just do surveillance, we just monitor them. Sometimes we can do radiation, very rarely prostatectomy in the salvage setting. Sometimes we use hormones, so we have choices. However, once patients develop metastatic disease, so remember, those are the patients where the overall survival at 5 years really drops off from 100 to 30%. Then that's where really the drugs come in, and that's where I do a lot of that work. So for patients who have cancer that has spread beyond the prostate, we typically divide them into 2 different groups. One group are patients whose mainstay treatment is hormones and their cancer is sensitive to the hormonal blockade. And here we do androgen deprivation therapy or ADT, hormones, plus usually another drug, either chemo or a more fancy hormone blocker. And we have a few of those available as options. Typically, that group of drugs is called novel hormonal therapies or NHTs. And more recently, we have 2 trials that showed us that using triplet therapy, meaning hormone plus a novel hormonal therapy agent plus chemo, results in improved overall survival. So patients who are able to receive this type of treatment live longer. And then eventually the cancer becomes resistant to hormones and patients develop something called metastatic castrate-resistant prostate cancer. And that's when you have to use other therapies with different, I'm sorry.
Code blue, medical emergency.
Okay, sorry about that. So, so in those patients with metastatic castrate-resistant prostate cancer, we have to use drugs other than hormones. And on the very right, I listed all of the drugs that we have in our tool basket. So the first couple are these NHT drugs, novel hormonal agents, which are just kind of fancier hormonal options. We have 2 chemotherapies that we can use, docetaxel and cabazitaxel. We have certain radiotherapies like radium-223 and the more recent one called lutetium PSMA. We also have immunotherapies, and we have a newer class of drugs called PARP inhibitors. And then more recently, including one FDA approval that came just yesterday, that's the very last combination, we've been using combination therapies as well for metastatic castrate-resistant prostate cancer. And if you would have looked at this list, let's say 10 years ago, I can tell you that half of the drugs that are currently there were not there. So this field really has moved forward by leaps and bounds. So today I wanted to focus on 2 different agents, which have been kind of interesting, have a novel mechanism of action, and have come about in the recent years, just to highlight progress. Next slide. So the first agent is called lutetium PSMA, which was FDA approved a couple of years ago. And this is a very interesting compound. So here I gave you a little slide of the mechanism of action. But basically, it's a radioactive lutetium molecule, lutetium-177, if you can think back to your periodic table days. And this molecule is linked to an antibody whose job it is to find a target. And in this case, the target is the PSMA molecule, which is frequently expressed on the surface of prostate cancer cells. Once the antibody finds the target, which is PSMA, then the whole molecule gets internalized into the prostate cancer cell. And then it's able to create some DNA damage inside the prostate cancer cell. And once the DNA damage is done, the cell cannot survive because cells with damaged DNA are marked for apoptosis or death. So this lutetium PSMA molecule is a radioligand that delivers a beta particle radiation to PSMA expressing cells and the surrounding tissue or microenvironment. Next slide. So how do we know that someone has PSMA on the surface of their prostate cancer cells? So we know that by doing a special type of a PET scan called PSMA PET, which is a requirement prior to delivering this therapy. And this is an example of what that looks like. But for example, you can see all of those black spots on the screen. They actually represent prostate cancer tumors that express PSMA. So we know that this particular patient has a target for this drug. Next slide. So the VISION study was the seminal study that led to the FDA approval of this compound. And the results of this study were published in one of our big journals called New England Journal of Medicine in 2021. Currently, this drug is FDA approved after failure of at least one novel hormonal therapy agent, and also at least one chemotherapy, which I listed to you before. Also, you must have a positive PSMA PET scan. This drug goes after both cancer spots in the bone and the organs. And this particular study enrolled 831 patients who received this drug every 6 weeks.
May I have your attention, please?
I'm sorry again, sorry about that. So patients received this drug every 6 weeks for 4 to 6 cycles versus best supportive care. And median follow-up on the study was about 21 months. Next slide. So this slide shows the results of the study, and we can go from top to bottom. The blue line represents patients treated with lutetium PSMA, and the red line represents patients who receive standard of care alone. And you have to remember that these patients are heavily pre-treated on this study at this point. They had multiple therapies. So in this case, using the standard of care arm is appropriate because these patients may not have had other options at this point. So the top graph shows us imaging-based progression-free survival. And you can see that the curves are very much separated. And if you look on the right, the progression-free survival was 8.7 months with lutetium and 3.4 months with standard of care alone. On the middle, we have overall survival, which is our ultimate endpoint. We always want to improve how long patients live when they receive a particular therapy. And here you can see that the curves are also very much separated, and that the blue curve is on top of the red curve. So in terms of numbers, the median overall survival with lutetium was 15.3 months versus 11.3 months with standard of care alone. And then they had other endpoints on this study too. One of them was time to first symptomatic skeletal event, which means what was the time to patient developing, let's say, a fracture or pain in their bones. And you can see that the curves are also very much separated and that they favor lutetium. So in terms of numbers, the median time was 11.5 with lutetium, 11.5 months versus 6.8 months with standard of care. Next slide. In terms of side effects, lutetium tends to be very well tolerated. I know it's a busy slide, but on the left, it lists essentially any side effects that occurred in 12% or more of patients on the study. And you can see that most of them included things like being tired, dry mouth, nausea, low blood counts, joint pains, diarrhea, decreased appetite, and kind of similar things. And also that serious side effects, which are called grade 3 or higher adverse events, did happen more commonly in patients treated with lutetium PSMA versus the best supportive care. However, all of these patients had to fill out quality of life questionnaires on the study. And the quality of life questionnaires did not differ between the two groups of patients, meaning that likely lutetium was able to treat their symptoms relating to the cancer, and their quality of life was good because of that. So the side effects from lutetium did not outweigh the benefits of lutetium. At least that's how I interpret the data. So this is now one of the tools that we have in our tool bag to treat prostate cancer with a very novel and interesting mechanism of action. And in terms of the future, this drug is now being studied in a variety of combinations with other drugs. as well as earlier in the disease course. So not in these heavily pretreated patients, but earlier on in the prostate cancer continuum. Next slide. And now I want to refocus a little bit. So the second class of drugs that I wanted to bring up was PARP, P-A-R-P inhibitors. And PARP inhibitors are kind of very interesting. They are a class of drugs that also have to do with DNA damage. And this is a slide that represents cells with damaged DNA. And our body is designed to repair damage in the DNA inside any cells, including cancer cells. Cancer cells actually have adaptive mechanisms to kind of have enhanced DNA repair because they want to survive and not be killed by the immune system. So the way that these PARP inhibitor drugs work is that they prevent the repair of damaged DNA. And then once the cell cannot repair the damage, then the cell is again marked for death or apoptosis and gets killed by the immune system. Next slide. So as a background, nearly 10% of primary prostate cancers and 25% of metastases from prostate cancer harbor mutations in this DNA damage repair pathway. And then about 8 to 16% of prostate cancer patients also have inherited mutations in the DNA damage repair pathway. So the prototypical mutation that you might know about is called BRCA1 or BRCA2. So these are kind of commonly reported in the media and are associated with a variety of cancers, not only prostate, but things like breast cancer, ovarian cancer, certain GI cancers, and others. And then there are also other genes in the DNA damage repair pathway, which I listed here, which are kind of less commonly known about. But there are several of them that potentially can be targeted by these drugs. And then there is another term I want you to know about. It's called HRR, or homologous recombination repair. And that is a mechanism to restore DNA integrity within this pathway. Next slide. So just briefly, we had a couple of studies with single agent PARP inhibitors. One is called olaparib, the other one is called rucaparib. And both of these drugs have been tested again in metastatic castrate-resistant prostate cancer that's been pre-treated with other medicines, including novel hormonal therapies, plus or minus chemotherapy. And they showed that, generally speaking, they have a decent single agent activity, meaning just with the one drug itself. Overall response rates tend to be between 35 and 45% with these drugs in the BRCA positive population. And because of that activity, they got FDA approved on their own in pre-treated prostate cancer patients. Next slide. And then more recently, we have been investigating combinations of PARP inhibitors with other drugs, particularly novel hormonal agents. So here I'm going to very briefly tell you about two trials that were very recently published and led to approvals of combinations of PARP inhibitors earlier on in the disease course. So these combinations are now approved in patients with newly metastatic castrate-resistant prostate cancer. So what these studies showed was that a combination of a PARP inhibitor plus a novel hormonal agent is more effective than combination of novel hormonal agent plus placebo. So PARPs do make a difference in addition to novel hormonal agents versus, again, novel hormonal agent alone. And these studies involved quite a number of patients, about 800 per study. And these studies enrolled both patients who had these DNA damage repair abnormalities and who did not. And although in the overall study population, there was a benefit, really the patients who benefited were the ones that had the DNA damage repair pathway abnormalities like BRCA. So because of that, the drugs were approved only in the DNA damage repair positive patients. And then the toxicities of the drugs were kind of as expected from single agent studies, nothing really surprising. So long story short, we have this very interesting class of drugs for some patients with prostate cancer who have certain genetic abnormalities, which kind of highlights the fact that genetic tests have to be done on these patients to discover these abnormalities to see whether they would be a candidate for these drugs. Next slide. And that's all I have. Thank you very much.
Excellent, Dr. Mara, wonderful presentation, and especially of discussing new and novel prostate cancer treatment. So the next part of our webinar is a Q&A portion, and I had a question for you. What are the frequency of treatment for both the lutetium, PSMA, and also the PARP inhibitors? How often are patients getting these treatments? Is it once a week, once a day? How's it administered? And things like that?
Good question. So PARP inhibitors are pills. So you basically take them at home on daily basis. The lutetium is a very short infusion given once every 6 weeks, up to 6 rounds. So 36 weeks in total, potentially.
Got it. And, at least in the urology space, we've had some challenges and had a lull in, gentlemen doing PSA screening and things like that. So have you noticed, with the changes and the frequency of when individuals are being checked for PSA for looking for prostate cancer, finding patients with higher grade and higher volume disease than you did in years past?
Yes, so this is a really good point. So a couple of comments on that. So prostate cancers that are aggressive actually make less PSA, which I don't think is widely known about. So those are the cancers you're really worried about. These are not the cancers you would do surveillance for. So sometimes patients come in and their PSA is barely outside of what's considered normal range, but they might have widely metastatic cancer. So what's important here is having prostate PSA trends, and you can't compare PSA between individuals, totally different. So normal doesn't really apply. You just have to do the screening and compare the PSA to previous values in the same individual. And yes, I definitely see kind of on the back end of less PSA screening and maybe COVID pandemic being there. I do see more metastatic patients on my end because they did not get screened.
Excellent. And so I'll finish. There's a question in the Q&A that we'll kind of kick off and then maybe get your input too. So the question in the is that what are the best options for low-grade prostate cancer? And our thought process in the urology space has changed over time. We used to find low-grade, low-volume disease, and often those patients would get treatment, specifically surgical treatment or radiation treatment. And what we found over the years is that not all prostate cancer needs to be treated. Oftentimes, low-grade, low-risk prostate cancer can be very safely watched over time. And we have a lot of patients that we typically would have gotten surgery in the past that we are now watching and following their PSAs and getting periodic biopsies in terms of management. So what we're trying to do, and which isn't any kind of advances in minimally invasive therapy other than not doing any type of aggressive therapy, which I think at the end is often in the patient's best interest. And so I will just, I guess, moving on to the kidney cancer space. And I know your talk was on prostate cancer, but Dr. Mara, are there any kind of new or novel treatments for advanced kidney cancer that are out there now that you're seeing compared to some of the things that we're doing in the past?
Yeah, absolutely. So the field really has exploded in the last 5 to 10 years. So 10 years ago, very bad prognosis with advanced kidney cancer, not much that we had in our tool bag. Nowadays, we have combination therapies for untreated patients, usually with immunotherapy and these targeted agents called TKIs. We also have development of multiple TKIs over time that still work even if one of them fails. We have a newer drug called belzutifan. It's a first-in-class HIF-alpha inhibitor. The person whose work contributed to development of this drug won the Nobel Prize. So, so definitely very exciting times, and there are newer compounds in development with novel kind of mechanism of action. So very exciting time for kidney cancer.
That's wonderful. I still remember even now that training, I had somebody I worked with that said that if you had metastatic kidney cancer, that the best treatment was a one-way ticket to Tahiti, you know, where the treatment options were so poor. And honestly, it was just so depressing when we'd see patients with really advanced cancer. So certainly it makes me feel better that there's all these new therapies out there and that we're really doing a better job with taking care of folks. And that will take us to another question that we have. What are the typical treatment options for clear cell renal cell carcinoma on the adrenal gland? Is a 4 to 7 centimeter tumor small, average, or large? And so it looks like the question is whether or not it looks like it's metastatic disease to the adrenal gland, and kind of your thoughts on that, Dr. Moore?
Sure. So there are some factors that are unknown in this case. So usually if you're talking about oligometastatic renal cell carcinoma, meaning that there's only one spot or maybe a couple of spots of cancer in the body, like for example, if you have just one adrenal tumor, sometimes you can deal with it in a more targeted, localized way, and you don't necessarily need to jump to the drugs right away. So sometimes you can do a surgery. Sometimes you can do radiation treatment. If something is small enough, you can do other techniques, like for example, freezing, something like that. So sometimes we can do that and then just observe with imaging and do nothing else. If you're talking about many sites of cancer in the body or multiple metastasis in one organ, then we can't really do the localized treatments anymore. And in that case, I would go to drug therapy as a way to control the cancer.
Excellent. Yeah, and I would totally agree. You know, our thought process on that has largely stayed the same, where you have and when you mean metastatic disease, generally one spot. You know, oftentimes the kidney cancer spreads to the lung space, and we work with our thoracic surgeons to remove that, and that's typically a good treatment option before the medications. And certainly, if there's a single metastatic site, then certainly surgery may also be an option for treatment. It looks like we have a prostate cancer question regarding recurrence rate removal versus focal therapy. So I can, you know, chime in on that. So prostate cancer and recurrence rate is largely dependent on how aggressive the disease is. Low-grade, low-risk prostate cancer typically has less recurrence rate and certainly less chances for the disease to spread than the higher rate and higher grade disease. So typically focal therapy is reserved for not the very advanced types of prostate cancer. And if it's localized to the prostate, oftentimes surgery is a good option. If you remove all the prostate, you can typically have pretty low risk of recurrence. Focal therapy is focused on one side of the prostate, and certainly if the patient develops prostate cancer on the other side, they could have a little bit higher recurrence rate. But it's kind of a balance between treating the cancer and also maintaining functional outcomes, specifically urinary incontinence and also erectile dysfunction. So it's a balance and generally a discussion with the patient and the physician. And then I think there's another question on here regarding kidney tumors and, you know, do all kidney tumors need to be removed? And, you know, what we found, at least in the urologic space, is that, you know, 20% of kidney cancers that are less than 4 centimeters or small tumors are often benign or are not really a malignant tumor at all. And so we've had a little bit of a paradigm shift in how we're treating these patients with small tumors. We are offering now more active surveillance, meaning we're watching these over time. So you don't necessarily need surgery. You don't necessarily need focal therapy like cryoablation. And generally, we're watching growth rates and how this changes, very similar to when Dr. Moore was discussing how PSA changes over time. And that it's not just the size that matters, but it's also the rate that these things are moving and changing over time. So to answer that question, not all tumors need to be treated, and it really depends on growth patterns. And certainly biopsy has become a more frequently utilized part of our treatment algorithm than in years past. And
just a very quick. Sometimes even if it's kidney cancer, it can come in different flavors or types, and some of them are also extremely slow growing. So I completely agree, not every kidney mass needs to be removed.
Excellent point. Now we can move to bladder cancer. The next two questions can kind of hit on that. So blood in the urine is treated differently in different people. Oftentimes, if you can see blood in the urine and you have risk factors, and smoking being the most common risk factor, that would be a sign of concern. Now, blood in the urine can come from urinary tract infections, it can come from kidney stones, but patients that have blood in the urine with a history of smoking, generally, it's something that we do want to work up and look for in terms of either bladder cancer or potentially kidney cancer. Oh, lost my light. Oh. The next question was, are there any non-surgical, non-invasive treatments? And I'll touch on that, and then if you have anything else to add, Dr. Marr. So often the bladder is a difficult organ to visualize. Imaging modalities such as CTs and MRIs don't pick up the lining of the bladder as well as looking at it with a camera. So at minimum, oftentimes patients need a camera to be put inside their urethra to take a look in the bladder, very similar to a catheter being placed, otherwise. And so in terms of treatment, generally local control or removal of the tumor is first line treatment. And then depending on how aggressive the cancer is, there are certainly immunotherapies and different types of chemotherapies that we can instill in the bladder. And if you have certain types of bladder cancer, chemotherapy and also radiation therapy is also an option, which would preserve the bladder, or what we call bladder sparing approach. Dr. Marr?
Yes, I agree. So really the ability to give a lesser invasive treatments for bladder cancer depends on how advanced it is and how deeply does it involve the wall of the bladder. So for non-muscle invasive bladder cancer, which is really the superficial cancer, Dr. Patel would be the expert to see, to consider minimally invasive treatments. For muscle invasive bladder cancer, minimally invasive treatments would undertreat that cancer because there is a possibility of seeding of cancer cells into the blood. So we have to use multimodality treatments, typically with chemotherapy or alternative agents, plus a surgery or radiation.
Excellent. I think we have time for one last question. And so that question is that if someone chooses focal therapy and cancer recurs, can a patient have the prostate removed at some point? And so that's a tricky question. So certainly you can have treatment for prostate removal after any modality of treatment, whether it be focal therapy or whether it be radiation therapy and things like that. In terms of a technical aspect of that, certainly removing a gland or a prostate that has not been treated is easier to do. And then side effects and risk of surgery go up if someone has had something done to the prostate. Now, that was typically seen a lot of times prior when we did prostate removal after radiation therapy. Data on focal therapy and prostatectomies or removal of the prostate afterwards is still kind of an evolving field. So the answer is you can have it removed, but certainly some risk are a little bit higher than others afterwards. Great. We'll turn it back over to you, Jennifer. Thank you again, Dr. Marr.
Thank you very much, Dr. Marr and Dr. Patel, for your fascinating presentations today. We appreciate your time. And in closing, we are very excited to announce that the 7th annual UCI Anti-Cancer Challenge will take place on Saturday, October 7th at UCI's Aldrich Park. It will be a hybrid event with opportunities to participate both in person and virtually. In-person challenge day will include a 5K, 10K run walk, 15 to 100 mile bike routes, including a new mountain bike route, entertainment, family-friendly festival, awards, and more. Next slide, please. So we hope that you'll consider starting, joining, or supporting a team, and all proceeds support promising pilot studies and early phase clinical trials that can help prevent, treat, and cure cancers. Next slide. We're hosting one more webinar in our series this year featuring renowned faculty speaking on hot topics in health, and more information can be found on our website. Next slide. We're also hosting several free in-person events leading up to Challenge Day, including rallies where you can participate in a training ride, run, or walk, and a research reception where you can tour the cancer research labs on UCI's campus. Next slide. So thanks again very much for joining us, and please scan the QR code listed here to receive more information. Have a great day.